You're good.
Hi, my name is Adrian Baddar. I'm one of the orthopedic surgeons at Hampton Roads Orthopedics and Sports Medicine here in Newport News, Virginia. I'm going to talk a little bit today about partial knee replacements. So this is a surgery that can be done for the knee and sometimes not recognized by a lot of people and they don't understand it, so I'm hoping to explain that a little bit. As we get older, we can unfortunately all expect to get arthritis in our joints. The cartilage that's on the end of the bones, while being a wonderful protection and means of moving our joints, it does not have any ability to heal or repair itself. So unfortunately, that means it can only wear out. And so over time, especially as we reach later on in life, we can expect that cartilage to do exactly that and start wearing away. Cartilage, again, that tissue on the end of our bones, has no nerves. And so when it's there, it's wonderful. We have no feeling from it. It doesn't cause any source of pain. But as it starts to thin away, then the underlying bone starts taking up the pressure from the joint. And that does cause pain. As anyone who's ever broken a bone would know, that can hurt quite a bit. That will cause inflammation in the joint, which will cause stiffness and soreness. It's interesting with arthritis that inflammation sets up the more we're inactive. And so the more we sit around, the more that stiffness sets in. And so that tends to bother us the more inactive we are. When we first move from sitting down after a while, it's really stiff, it's really sore. As we start and continue to move, though, that pain usually will subside and get better. So that's one of the interesting things about arthritis. It tends to hurt us more the more inactive we are, so laying down, sleeping, sitting around. Whereas once you get up and get going, it feels a bit better. The treatment algorithm for arthritis, unfortunately, is somewhat limited. Anti-inflammatories, so things like Advil, Aleve, there are, yes, some prescription drugs that we can use. Those help to minimize the inflammation, but they do nothing to fix the arthritis. You can do injections. There's different types of injections. A lot of that depends on which insurance you have, unfortunately. The most common thing that's injected into a joint is what we call cortisone or corticosteroids. Those are steroids that are put into the joint. Again, we're using them as a very strong anti-inflammatory. The nice thing about that is you get to put it where you want it and let it really kind of work where you need it the most. The downside to it, in diabetics, they can be a little sensitive to it. It can raise their blood sugars a little bit. There is a theoretical concern that doing them too frequently can cause more damage in a joint. And so when you run into people like us, we do have typical limitations on how frequently we're willing to do that. In a knee, that's typically around every 3 months. We don't really want to do it much more often than that. Again, there's other medicines like lubricants and things like that you can inject. Again, that's very insurance dependent. The shots themselves also are not fixing the arthritis. They're there to just calm it down and make it more tolerable. How well they work, how long they last are very independent from one person to another and how severe the arthritis is, and so that can be very variable. When we've burned through and used up all the different conservative treatments, that's typically when we start talking about surgery. Okay? When it comes to arthritis, again, wearing out of that cartilage, we cannot put that cartilage back. We have no means of doing that in a broad sense over a joint. If there's little focal areas where people damage a very small area, that can be done, but that's not typically what we understand as arthritis. Arthritis, we typically mean that the weight-bearing area is really denuded of the cartilage, and so we can't really put cartilage back over a large area like that. That's just not possible. And so for most people, what we're going to be talking about is joint replacement, and most people understand the concept of a full knee replacement. I have a little model here of that. With a full knee replacement, we're going to resurface the entire knee. So we're going to put a metal cap on the end of your thigh bone, your femur, and it's going to cover the whole surface. Okay, we get that to fit by shaving off a little bit of the remaining cartilage and a little bit of bone. And then on the shin bone or tibia bone, we're going to do the same thing. We're going to remove a little bit of the top there, and we're going to put a metal plate that fixes down into your bone. It actually has a little keel in there for fixation, which I can demonstrate. And that is fixed to your bone. And then there's a little plastic or polyethylene spacer in between there. So everywhere that was before rubbing bone against bone is now metal against plastic. And you don't have any nerves in the metal, you don't have any nerves in the plastic, and so that arthritis pain is gone, okay? But this is a big operation, and I always tell people that it's a quick operation. We've gotten very good at it over the decades. This is an operation that typically is done under an hour routinely now, but it's still a big operation, which means it's a big recovery for patients. I typically tell people it's going to be several weeks of physical therapy. It's going to be a good couple of months getting over most of it. The full recovery is about close to a year. Most people can expect to be on a walker for a couple of weeks. So while it's a great operation and it does really well, it's a big operation. And a lot of times this isn't necessarily what people fully need. Now, if somebody has worn out their entire knee, then this is going to be what we would recommend. And so to back up a little bit, I'll tell you that with the knee, we tend to think of the knee as 3 compartments, okay? Very simply, the inside compartment, the outside compartment, and then behind your kneecap, okay? In the majority of cases, as people start to get arthritis, they will wear out the inside preferentially. Now, that's not true on everyone. There are some people who get a more knock-kneed arthritis and wear out the outside preferentially, but that's probably 10 to 20% of the cases. The grand majority wear out the outside. Some percentage will wear out the kneecap side. If people don't have a lot of stairs or climbing or issues where they're bending their knee a lot, then kneecap arthritis can actually be very well tolerated. But the inside, the medial joint space arthritis, actually, it can be very painful, and that's usually how most people present is with medial side arthritis. And so if somebody has arthritis that is isolated to the inside of their knee, then they could be a candidate for a partial knee replacement. And this is a model of a partial knee replacement where we're just doing the same idea as a full knee replacement, but we're only resurfacing the part that's affected. So in this case, so this would be a left knee for me, we're resurfacing that medial femoral condyle with metal, again, putting that metal cap on the end there, a metal plate on the shin bone, but just on that medial side, and then that little plastic spacer. So the end result is the same. You get the metal against plastic, which you don't have the nerves in, but this is only affecting 1/3 of your joint. So that same operation has been reduced by roughly 1/3 of the operation. And so this is 1/3 of the operation, and I tell people it's about 1/3 of the recovery, okay? Further, we're not doing as much to change your knee. This being so limited, really this knee is still mostly you. 2/3 of it is still you. And so this ends up for most people being a lot more natural feeling. There are 4 major ligaments in your knee. You can see about the little rubber bands here that representing the collateral ligaments. But inside the center of the knee are your ACL and PCL ligaments. Now, when we do a full knee replacement, every manufacturer who makes a knee replacement, the ACL gets sacrificed. Now, the knee replacements build in the function of the ACL, so it's not as crucial. Some of them also have the ability to remove and replace the PCL, ligament in the back. But with a partial knee replacement, we're not affecting the ACL and PCL, so those ligaments are left intact. And I think a lot of the reason with a partial knee replacement it feels more natural is because those ligaments have nerves in them, what we call proprioceptors, that allow to know where your knee is in space and how it's moving and what's going on with that. And so if those ligaments are all left untouched, it's going to feel more like a natural knee. Another big issue with partial knees, again, is people have to have just their arthritis isolated to that one compartment. They can have some arthritis behind the kneecap. They can have some arthritis on the outside, but you don't want that to be severe arthritis. If that's the case, and if that's bothering them, they're going to be better off with a full knee replacement. But if their pain is isolated to one compartment, then this could be an option. We always say in orthopedics, the best candidate for a partial knee replacement is someone who you say, where does it hurt? And they point to the one side. That's, a good indication that it's just partial arthritis in the knee. You cannot have, there are more conditions with a partial knee replacement as well that differ from a full knee. With a full knee, we can pretty much reconstruct anybody's knee, even if they have ligament damage, even if they have significant deformity, we can correct that with a knee replacement. It might take a little bit of a different kind of knee replacement, but it's doable. With a partial knee replacement, we don't have that luxury. So if people have a lot of stiffness, if they can't really fully straighten their knee, maybe a few degrees, we can overcome that. But if they're missing about 20 or 30 degrees of straightness, it's not really the best option for them. Same with bending it. If their bend is very limited, that's not going to be a good option. We'll have a hard time correcting that. if their knee is really crooked. So if they're really bent to one side, that's also something we're probably not going to be able to correct with a partial knee replacement. You'd be better off going with a full knee replacement. But in the people where this is an option, again, this is a really good option. And I think, unfortunately, it's not well known as a full knee replacement. I think so. A lot of people aren't aware of it as an option. Again, though, as a surgery, this is going to be a much easier surgery for patients. This is actually being done as an outpatient surgery where people come in, have the surgery, and go home the same day. Of course, obviously, if people are a little more in need of a little more care, they can typically spend the night. Almost no one needs to be in a facility after that next day. They all can leave within that day. Almost no one requires rehab after this in terms of like going to a rehabilitation facility. That's just not necessary. We do recommend physical therapy after this. Again, with the total knee, I was saying it's several weeks of therapy. On average, it's about 6 to 8 weeks of physical therapy for a full knee replacement. With a partial knee replacement, therapy can be as short as a couple of weeks. It's amazing. People regain their motion and their strength fairly. Replacement that people are on a walker for a couple of weeks. With the partial knee replacement, people are off of walking aids usually within a few days. We'll check people back at a couple of weeks, and most of the time they come walking in. Now they're still a little sore and they're still a little swollen from surgery. That's to be expected, but usually they're doing fairly well and advancing fairly rapidly. Most of the recovery is actually over within the first month. Okay. Again, there can be a little bit of residual healing that goes on for a few months, but it's not near as the recovery as it is for a full knee replacement. So this is a really nice option for an easier recovery, for an easier surgery than a full knee replacement. One of the other caveats I tell people about, and this is a little bit of a sensitive topic, but it does need to be addressed. The partial knee replacement is a smaller implant. So it is prone to seeing the stresses, the same stresses that a knee sees, but over a smaller area than a full knee replacement. So unfortunately, weight is an issue. So I have a set of weight limits for different implants on knee replacements. Unfortunately, women tend to have smaller bones, so they get smaller implants. So I have a lower weight limit for females than I do for men. Again, a lot of it depends on the size of their bones and the size of the implants, but weight is an issue. Typically around 250 pounds. Above that, you really are hesitant to do it. And the reason being is that this could fail prematurely. Typically with a partial knee replacement and a full knee replacement, you hope to get to about 15 to 20 years out of those implants. And so you don't want something that's going to wear out prematurely. It's not really worth doing a replacement that you're only going to get a few years out of. In my mind, you're better off just doing the bigger surgery and getting something that's going to last much longer. The 15 to 20 years has typically been something that we quote from studies in the past. There were implants both in the full and partial knee have evolved since then. We think the newer ones are going to last longer. That science and that proof has yet to be determined yet. These newer implants have only been being out there for about 10 or 15 years. So it does look like they'll last longer. I'd like to claim that they will. But you really want to get something that's going to last a long time if you can. So again, I'll just summarize. So partial knee replacement I think is a wonderful option. You have to fit into the criteria for that, unfortunately. So arthritis isolated just to one part of your knee, not a lot of deformity, not a lot of stiffness. People locate the pain where that arthritis is on the one side. You can't have ligament issues with the partial knee replacement. We're relying on those. Weight, again, is a factor. But if you meet all those criteria, then this, I think, is a very good option. It's going to be a much easier operation. Again, can be done as quickly as an outpatient surgery where you go home the same day. It's going to be a much easier recovery, very limited therapy needed afterwards. The risks are, I think, a little bit nicer than the full knee replacement even, and a lot more natural feeling, which is a nice little bonus. And the longevity of this should be close to what a full knee replacement is. And so that's a nice solution there as well. So that's my little talk on partial knee replacements. I hope you find that information helpful. If you have questions or concerns about that, please contact us at Hampton Roads Orthopedics and Sports Medicine. Again, my name is Dr. Adrian Baddar. Thank you.